a number of seminars with people who are presenting and also people who are responding to these presentations during the day. And we are now looking forward to the first moderator and this session about patient involvement from passive to active when the patient contributes to improving the quality and safety of his or her own care. And the moderator is Anna Teufel from the Austrian Network for Patient Safety. Please, Anna.
Thank you very much, Pernilla. Yeah, and welcome to this first session after this inspiring keynote. In the next hour, as Pernilla just said, we will focus on patient involvement. The importance of involving patients and their loved ones in healthcare has become clear in the recent years, as shown in the World Health Organization's Global Patient Safety Action Plan 2021 to 2030, with patient and family engagement being one of the 7 goals named in said action plan. With the slogan, "Elevate the voice of patients," patient involvement was also the topic of this year's World Patient Safety Day, as we've heard before. However, there is still room for improvement in this area. For a long time, a paternalistic approach was predominant, which is only slowly and laboriously being overcome. The expected benefits for patient safety linked to patient and family involvement are well known, such as reduced stress for patients, better preparation by patients for an examination, an operation, a treatment, and better self-monitoring of possible post-operative complications. Nevertheless, not only the patients benefit from involvement, but also the healthcare professionals and the resilience of the system as a whole benefit, as patient involvement can result in access to quality information to facilitate diagnosis, to less rescheduling of care due to poor preparation, and a reduction in the impact of post-operative complications. When the quality of the interaction goes so far as to involve the patients in the most crucial decisions, both patients and healthcare professionals experience more meaningful and humane care. However, these gains can only be achieved through involving both patients or their representative organizations and the practitioners and hospitals in which they work. The game of patient involvement cannot be played where nothing has been prepared to welcome a more proactive patient. Practitioners would be annoyed to have to deal with patients who ask a lot of questions, and patients would be frustrated if their involvement was not appreciated. So today, we will address exactly this question. What happens when we move from passive to active, when the patient contributes to improving the quality and safety for his or her own care? First, we will have 3 short talks to shine a light on the situation in different European countries, Austria, Belgium, and also Norway. And afterwards, we will discuss this further on the panel. The first speaker I would like to introduce is Dr. Daniela Royatz, who is working at the Austrian Public Health Institute GÖK as a health expert and project manager. Since last year, she is working in the newly founded Competence Center Health Promotion and Health System at GÖK. Her work focuses on projects to strengthen self-help organizations, citizen and patient participation, as well as activities for the systematic implementation of disease prevention, health promotion, and health literacy in primary care units. She will give us an insight into national programs on patient engagement in Austria. The floor is yours.
Thank you very much, Anna. Good morning, ladies and gentlemen. Thank you very much for the opportunity to introduce a few insights in the Austrian way of patient participation. And I allowed myself to extend the title not only in patient safety, because I think patient participation is not only an issue in patient safety, but in general in healthcare decision-making. I will start with the term patient participation. Anna used the term involvement, the title says engagement. So there are a lot of terms, partnership as well, dealing with this issue of participation in decision-making. And that's also, of course, for its ambivalence. So we have the Global Patient Safety Action Plan stating patient engagement and empowerment is perhaps the most powerful tool to improve patient safety. So a strong argument for doing patient participation and engagement. On the other side, we know practice projects and also literature reviews and articles like the one I presented you from Forward and colleagues, stating that different understandings of participation are one of the biggest hurdles to implementation. So we know patient participation is old but not easy, but important. And so I will try to just make a few differences. The first is, I think it's quite important. It's simple, but important. It's the one between individual patient participation, so shared decision-making and participation in individual treatment decisions on the one side, and collective patient participation on the other side, so decisions on healthcare structures and procedures, which is also important. It's much more advanced participation, of course, but it's also important. That's not only the decision in healthcare treatment, but also on the meso and macro level. And I will try now to give you a few insights into engagement in patient safety in Austria and also engagement in the broader perspective of healthcare. We will start with engagement in patient safety. First, there's a patient safety strategy in Austria, so we are one of the countries in the opening who were mentioned, and it's a strategy to guide and to raise awareness about the diverse topics and issues important to patient safety. And it is also emphasized in this document, the individual patient participation and its importance to increase patient safety. On the other hand side, we have also boards on a more strategic level, like the Patient Safety Advisory Board. It's a board to advise the Ministry of Health in Austria, and there self-help organizations and patient advocates are members. So there is patient participation in practice. And we have also the Austrian Patient Safety Network. It was already introduced, so I don't have to talk about it a lot, but it's a network where also the National Self-Help Organization is a member. So there's also patient participation on a more strategic level. Now we will shift the perspective to the broader perspective of healthcare. And there is the Austrian Platform for Health Literacy with the overall aim to strengthen health literacy in Austria. And there are four main working areas. There's one about good communication in healthcare. So it's important that health professionals are trained to communicate well with the patients, because communication is key, as we all know, in patient treatment. Then it's about good health information, so written information material, which is evidence-based and target group orientated, so that people can understand what is written and it's not Latin words or something like that. It's about framework conditions in organizations. There are self-assessment tools on health-literate healthcare organizations, health-literate primary care units. And the fourth pillar is about citizen and patient engagement. For example, Ask Me Free, so empowering patients to ask questions so that they can make good decisions on their health. And on the other side, on a more strategic level, there are already in place standards for public participation in Austria. It's not limited to the healthcare system, but it encompasses the whole Austrian policy areas. And the standards are just recommendations to involve public in decisions which are big, controversial, and there's a guidance on how to do this. So it's a recommendation. It's not a law, so we do not have to do it, but it would be advisable, of course, to do this. But we have the patient charter. It's a contract between the federal states and the Bund. And there are 3 articles stating or referring to patient participation. One is that we have to establish independent patient representatives. And these representatives, Patientenanwälte, they are called in Austria, kind of ombudsmen, have to work together with self-help organizations. And self-help organizations, especially the umbrella organizations of them, have the right to and the opportunity to review relevant laws and regulations. So it's also stated, and we have a few strategic documents, that's the message, stating that patient participation can happen, and we focus thereby by involving self-help organizations. On the next slide, coming to the broader perspective, we also try to strengthen patient participation in the healthcare system on a larger scale. And as you see on the timetable there, we're working there since the last 10 years. And there were different expert reviews. The first I know was 2014, contracted by the Ministry of Health in the framework of health literacy. Another also in the framework of health literacy, commissioned by the Austrian National Self-Help Organization in 2015, also deals with patient participation and opportunities. And this review report provides also a first idea how a patient participation strategy could look like. It's not said it has to be like that, but it's just some food for thoughts. Then 2019, there was another expert review report contracted by the social insurance. And this report closes with open questions, which have to be answered on our way and road to more patient participation. And the most recent one was the one just finished this year, was a feasibility study on citizen and patient participation in the healthcare system. And the speciality of this report is that it was not just written based on literature and a few expert reviews, but also on workshops. So it was really a participatory process involving patients, potential patients, social insurance representatives, federal states representatives, and others to find together an idea what we need to do in order to enhance patient participation in Austria. And the report concludes with 3 recommendations. The first is to implement or establish a competence center holding the space for participation, providing further education on participatory methods, connect the field, provide standards, tools, and information on participation. The second recommendation was to establish an online portal, making the patient participation projects and processes which are already in place, and we know that there are patient participation happen already, to make that transparent and to learn from each other. And the third is an online forum, a network of civil society organizations trying to advocate for their interest in healthcare system, to connect them and empower them to speak with a stronger voice. So that are the recommendations. We're not yet there to fulfill them, but I will show, And then another interesting document is a roadmap in the area of health promotion. There was a foresight process thinking about the future of health promotion in 2050. And one of the results was also making the case for participation and its importance, not only for patient safety or healthcare system, but generally for health. So strengthening both population participation and involvement is key to increase health as one of the key messages with respect to participation. Yeah, coming to an end, I will just share a vision for the future of patient participation in healthcare. It's just an idea, it's not yet in place, but the idea would be to have really kind of these national standards for patient participation or public participation in more general, just to have a real guidance for all spectrums. Is it economy, is it is it climate, is it healthcare system? No matter what, I think patient participation is important, no matter where. And then to draw from this more specific a national action plan, strategy, however this will be called, to have just guidance how we can implement participation in the healthcare setting, and then also have a good framework and a basis to work more towards patient participation in patient safety. Thank you very much.
Thank you, Daniela, for the insights in the Austrian programs, and we will see you on the panel in a minute. Next up, we have Dennis Erbeau, who is a board member at the EUPSF and the CEO of the Platform for Continuous Improvement of Quality of Care and Patient Safety, and expert for the International Society for Quality in Healthcare. Furthermore, he's a professor of health economics at Université Libre in Brussels, and we're looking forward to the Belgium experience with the patient-reported incident measure.
Thank you for the introduction. Good morning, everyone. I'm really happy to be here today as a board member of the EUPSF and to be allowed to present you the Belgian experience regarding incident measured by patient-reported incident measures. So that's my bio, but it's already down, so we can skip it. Just a few words about my organization. It's important to understand how and why we launched this project. So my main job is working at PAX, which is a not-for-profit organization celebrating its 10th anniversary already. Time flies. We are quite small, only 6 people, but we're trying to make a difference with this team. We are gathering different stakeholders of the Belgian healthcare system. So healthcare institutions, hospitals, long-term care, starting to work a little bit with primary care, but it's not that easy. Sickness funds, which are in Belgium kind of public body responsible to represent and reimburse patients for the care. Professional association, physician, nurse, pharmacist, quality manager, university, and also the regional authorities. Belgium is really complex. I'm not going to give you an institutional course about Belgium, but basically we're working both in Wallonia and Brussels. That's 2 out of the 3 Belgian regions. Our job is quite simple. Well, it's hard to do, but it's easy to write. It's to support healthcare institutions to improve quality of care. And we recently refine our vision, which is now stated as what we want to achieve in Belgium is really to have a quality culture rooted in daily practice. It kind of resonates with what Anthony said earlier, is basically we know what to do, now we have to do it. We have to implement it, and that's really the job we want to do. And to fulfill this vision and this mission, we organize different kind of programs, different kind of, and we're making resources available for the institution, for the professional, but also for the patient. And we're organizing training focusing on leadership, improvement science, and teamwork. So that's basically what we're doing. Let me bring you back a few years ago, back in 2020. We published a regional strategy to improve patient safety. The reason why we did that is first, there was no such strategy in Belgium at that time. And the second one is they're also reasoning with the previous speech that we had this morning, is that we truly believe at PAX that safety is a cornerstone of quality. We cannot achieve high quality of care without having safety in healthcare. So that's really the reason why we developed this strategy, and that we really working hard to make this strategy to make patient safety at the top of the agenda, again, to rely on what Anthony said earlier. So our strategy is composed in 5 axes. I'm not going through all of that, but the first one is about monitoring and steering patient safety. And this is obviously really important because, again, coming back to the opening speech, we cannot improve what we cannot measure. We need measures to know where we are, what are the difficulties, on what we have to work on, and to see if we succeed or not by working on this. So this is really important. And in Belgium, unfortunately, we do not have such figures. We do not have any study assessing where we are in terms of patient safety. We have a lot of initiatives, a lot of programs. We have some quality indicators, more or less, I would say, good. We have some public reporting, and I'm not saying it's the best thing on earth, but that's something that exists. Also, our hospitals are getting accredited. Again, I'm not saying it's the best thing on earth, but they are doing it. So we have really a lot of things, but what we are still missing, in Belgium at least, is the big picture. Look at the healthcare system, look at patient safety, where do we stand? What we have to work on. And so that's really why it's the first axis of the strategy. We need now to have some figures. Going to an OECD report, they pointed out that regarding adverse events, there's 3 big ways to collect them. The reporting within the institution. Most of hospitals, at least in Belgium, but I suppose it's the case in most OECD countries now, do have this kind of reporting. not the best things, but it really helps to kind of feed the improvement. A second way is to use structured data routinely collected. Quite hard to do, and I'm coming to that point at the end of my speech. And then is looking at patient experience. And that's basically why we embark in this project, pilot project, led by the OECD, so we embark in it right after the first wave of the pandemic, back in 2020. Actually, the project began a little bit earlier, and so we embark in this project in which the OECD co-developed with experts and with patients a questionnaire, kind of an experience questionnaire, but focusing specifically on incident, with three main areas: how to prevent incident. Is there any prevention around incident, the reporting of incident, and also the management of incident? So this questionnaire was in English, and so we work in different steps. The first step in Belgium, and again we're working in the French-speaking part of Belgium, was to translate basically the questionnaire and to validate it, this translation, with both professional and patients. So that was the first step, and making sure that it makes sense for the professional, but also that it makes sense and that was understandable for the patient, because otherwise it's useless if they do not understand the question of the questionnaire. Then we use the sickness funds to spread the questionnaires. The added value of having the sickness fund with us on this project is that every Belgian citizen has to be affiliated to one of the sickness funds. We have 5 of them. That means that starting by the sickness fund, we basically can contact all Belgian citizens. Obviously, we selected the people we wanted to touch. It was people who went to hospitals 3 months ago, etc. So there was some criteria. We select them. The Sickness Fund sent more than 20,000 emails. We get a response rate of 5%, which is not high, but it's high enough to work with the data we collected. We analyze this data. Basically, it's representative of the Belgian population, so we can at least start working with this first data. The first result is not that good. Is that more than 15% of the respondents said that they experience at least one adverse event. So they could be biased. We can discuss a long time around this figure, but it's one figure that shows there's a lot of people. And as you can see in the graph, you can find all this in LSAT Glance, the last version of LSAT Glance from the OECD. We are the extreme right. So we have to work on. There are other results that I would like to share with you today. Among these 15, a little bit more than 15%, and that's the first point, we have the opportunity through this questionnaire to see what kind of adverse event happens. This is also really important because when designing policy to improve patient safety, it's obviously important to know what are the priorities to work on. It's one thing to know that there are a lot of adverse events. We wish it would not be. But if there are, on what kind of things we need to work, what kind of policy we need to design to work on this event. And so if you look, most of them concern both procedures and medication. Again, this is the patient perspective. So this is what the patient experiences and what he thinks happens. So this is not a scientific analysis. This really, but it's really important, and I'm coming back to that. But this is really the patient perspective, falls, obviously, and healthcare-associated infection. I'm skipping the second point. I will come back to that later. We also find through the data that there is a positive correlation with the length of stay. The longer hospital stay is, the more patients report adverse events. And we also find a negative correlation, both are statistically significant, with health status. That's not surprising, but that's also important to know when designing policy and to see on what you have to focus. Communication seems to be considered quite good, which is a good thing. But I really want to outline 2 results that, in my view, are really bad, starting with the last one. When you see that 15% of respondents fell again, that's a feeling, but felt that the information about the discharge from hospital was not well communicated. That's kind of a high number, right, in terms of quality of care, in terms of equity also, because we know that there can be difference with different people. And that's something that in healthcare we know for a long time now, that it's really important to provide the good information, accurate information, understandable information for the patient that leave hospitals. So that's really not a good sign. Another result, which is even worse, is the second one, where you see that, again, from patient perspective, when experiencing an adverse event, 40% of them think that this event was not ended well. That basically, healthcare institution, healthcare professional did not do what they had to do to explain what happened, what could be the consequences, did not excuse or explain things. And that really pointed out how the fact that we know what to do, but again, coming back to Anthony, now we have to do it. That's really something we have to work on, because again, reporting is one thing, measuring is another thing, but then we have to work on, and that's really pointed out that there's big challenge around that. A few words to conclude. For us, this experience was really, really good, really promising. As I said, it gives you really different kind of information than using the adverse event reporting system from hospitals. With this patient perspective, things that you cannot find in the adverse event reporting system from the hospitals. So that's for us really the added value of this. Another big lesson for us is, and that's not a surprise, but by working together, we're working better. This project could be built and run because we've been working with the professional and patient to validate and to use the questionnaire, but also with the payers, because basically sickness funds are the payers, to be able to get in touch with many patients and get their perspective on that. So it's just good. It's also helped us, and that's coming back to the OECD report, to compare with other countries based on the same questionnaire. Context is not necessarily the same, but again, that's an opportunity to discuss and to compare and to try to learn from each other. And finally, this really fit into the PACS strategy of improving the culture of quality within the hospital. Finally, as I said, one of the big challenges is also trying to use routinely collected data to be able to really monitor all along patient safety, but that's something really hard. But hopefully next year or the year after, I'll be able to talk to you about that, because we probably will launch a research study on that beginning of next year. Thank you.
Thank you, Dennis. We will see more of you in the following session on safety and culture. The third insight comes all the way from Norway. Please welcome with me Dr. Christine Harris. She's a research fellow in the Department of Anesthesia and Critical Care at Haukeland University Hospital in Bergen, and associate professor in the Department of Health and Care Sciences at the Western Norwegian University of Applied Sciences, also in Bergen. And you will talk about the surgical patient safety checklist you have developed in order to prepare and involve patients stronger if they have to undergo surgery.
Yeah, thank you so much. And thank you so much for inviting me and allowing me to present this project. It's an ongoing project, so it's a project that's still going. Yeah. So everyone knows that World Health Organization has said that recognized that to further improve patient safety, we have to involve patients in their own safety. And we know that the patients are always the center of their own healthcare treatment, and they stand in the middle, and the healthcare workers, we come and go. They are the ones that are observing almost all of the treatments, even though they don't always understand the medical issues or the terminologies and everything, but they are there. So we know that it's very, very important to involve patients into their own safety. So the beginning of this project was basically based on the Safe Surgery Checklist, where my supervisor, Arve Steinar Haugen, presented his PhD to the patient representatives at the hospital where I work. And one of the representatives actually said, what about us? What about us? We should have a checklist as well. So we started looking into what is out there, and we didn't find very much. We did find this article which recommends us to develop such a checklist, but we couldn't find many checklists for patients. The only ones we did find were specific to surgery, certain surgery, and they're mostly discharge checklists, but they did show a reduction in length of stay and also a reduction in readmission to hospital. So we went on this journey to develop a patient safety surgical checklist, and it has been developed in 2 Norwegian hospitals across 6 surgical wards. This development has been developed and validated and was a part of my PhD project. And the aim was to develop a general surgical checklist that could be used by most surgical patients, not just one specific specialty. And we were wishing that they could empower the patient to be more involved in their own safety and to prevent harm. So a little bit about how we did develop the checklist. During the development and the validation of the checklist, we interviewed 25 post-surgical patients that had surgery, and 27 healthcare professionals across the 6 different surgical areas. And we asked them, what can the patient do to be involved in safety, their own safety? We then identified these risk areas through analysis, and we developed a surgical checklist through a consensus process where we had healthcare professionals, doctors, surgeons, nurses, physiotherapists, general practitioners, and also nutritional experts and pharmacy personnel. And we went through the checklist, and we ended up with a result, a temporary result of the checklist. Then we asked 215 patients to validate this checklist by answering on each item if they thought the item was important or not. And by doing so, we could rule out some of the items, but before we did remove them, we did something called a hazard scoring to make sure that we didn't remove anything that could cause an implication for the patients. And here's an example of the first page on the first checklist. It's divided in 2 parts, one before and one after surgery. And basically what it is medication safety. It informs the patient about how important of them having their own medication list updated and controlling their medication, including temporary withdrawal, holding of anticoagulants before surgery. It also encourages patients to how they can optimize their own health before surgery. And it also includes something called self-malnutrition screening, where the patient screens themselves for undernutrition. And also it helps them know what to prepare for before surgery and the importance of understanding the information and clarifying unclear information. It also, at the last point, it follows the patient all the way up to surgery, and at the last point, it also informs the patient to request the use of World Health Safe Surgery checklist. The preoperative checklist has a total of 29 items, but some wards have an additional item, so we have been adjusting it a little bit depending on the ward's flow and needs. And the second part of the checklist contains elements such as information about which complications they should be aware of when they come home and what they should do if they do experience a complication. And the importance of understanding why they should be adhered to restrictions or being active. importance of information about new medications or medications that have been stopped before surgery. Should I start them again? When should I start them? And also how to use their pain reliefs afterwards. We interviewed several patients that did experience a lot of pain after surgery when they got home, and I didn't know what to do. And also further plans for treatment and follow-ups. Sometimes we hear stories about patients being lost in the system and patients just waiting and waiting, not actually contacting when they don't hear anything. The post-operative checklist has 21 items, which is quite long, but each item on the checklist, when the patients fill them out, they get an instruction. So if it has an impact, they get told to do an action. So patients receive the checklist approximately 8 to 2 weeks before surgery and use the perioperative checklist all the way up to the surgery. And currently it's being transferred to the medical records. Then after the surgery, they use the post-operative until discharge. However, we do see the importance that healthcare workers need to be involved in this. They also have to pull out these checklists and use them together with them. So the implication for praxis so far is that we see that firstly, it increases patient involvement in patient safety. And secondly, it changed the way healthcare professional gives patient information by allowing patients to receive important information at an earlier stage than before. And thirdly, it's systematically information flow. And fourthly, patients are encouraged to plan their surgery better, to establish contact with general practitioner and the surgical wards if it's needed. The checklist acts as a guide for the patients, allow them to ask questions and to clarify information when they meet healthcare professionals. And lastly, it's an indication that these checklists should be taken to other fields as well, not just surgery. So it's been a travel. That was my first part of my PhD, and after that we did get funding from the Norwegian National Research Council, and we developed this as an electronic platform. And this is a platform where the patient gets sent out the checklist, and they fill it out and answer it, and it returns back into the medical journal or records. And the next step in this project is to test out the effect in a step-based randomized controlled trial. And this is an ongoing project. And it is 4 work packs, and we're going to look at the effect. We're going to allow the patient to screen them for undernutrition, and they will get consultations if needed. And thirdly, we will investigate the implementation process of the checklist across the different to see what is the best way to implement this. And lastly, we have also a PhD student that's looking at patients' health literacy in the 2 groups, the ones that do get the checklist and the ones that don't get the checklist. And this is just a little overview. We're just about to finish our data collection, and we have a total of approximately 5,320 patients in this study, and results will follow, but that's what I have so far. Yeah. And that's my research group. Thank you so much.
Thank you, Kristen. Now we continue with the second part of the session, the panel discussion. I would ask all the panelists to speak very fast, because otherwise we won't have any coffee break. Yeah, just sit anywhere. And first up is Dr. Annemarie Friedrich. She's the head of the Swiss Patient Safety Foundation. In addition to initiating new programs and projects, she maintains an active exchange with all stakeholders in the healthcare sector, and she's very keen to intensify national and international networking in the field of patient safety and to raise awareness of the topic of patient safety on a broad level. And the second new guest on our panel is Professor Mike Durkin. He's the chairman of the governing board for the Patient Safety Movement Foundation. He's an advisor for numerous organizations, for example, at the Institute of Global Health Innovation at the Imperial College London, and he's the academic director of the Global Patient Safety Collaborative, a partnership between the WHO and the UK government. And he's a qualified physician and held clinical research and teaching positions in cardiovascular anesthesia and critical care in the UK and also in the US. So you have two perspectives to bring to the round today. And he also served as the NHS National Director of Patient Safety. And those two ladies on my right side, you already know, so I will skip the introduction in order to save time. First, I would like the newly added speakers on stage for their thoughts. How can this shift from passive to active be achieved, and what are the factors you have in mind, you have to bear in mind in doing so? What are your thoughts on that? And I think you have a microphone up there.
So, as Anthony said, patient involvement is becoming mainstream. So also in Switzerland, it's a topic that's discussed a lot. But what we often find in Switzerland is that there is a lot of uncertainty about how to involve patients and their families, and how to get in touch with the right persons, how to organize this whole process of patient involvement. And we think that there are guidelines and standards needed, as Daniela also already said, and that we also need some support structures for healthcare service providers who would like to involve patients, and also more information and training programs for patients and their families who would like to get involved, and also very specific tools and programs like checklists, like Kristin said, and or platforms. We recently launched a new platform where patients and families can report critical incidents. So like critical incident reporting systems for healthcare stuff. But this is a platform where really patients and the families can report such incidents.
Perfect, thank you.
Thank you, and thank you very much for asking me to come and join you. It's great to see such a wide group of people from across Europe getting together to talk about these issues. So thank you for the invitation, and I'm looking forward to listening to the rest of the day. I think there's so many multiple issues going on here at the same time that I always break it down into sort of bite-sized chunks. And for me, what I've learned over the last 25 years or so in this field is that it's very difficult to break out. When we talk about patient and family engagement, empowerment, participation, I always think about the word fulfillment. Are any of those elements giving our patients and their families a fulfilled experience when things have gone wrong? And I'm balancing that on the other side of the equation, which has been brought into huge relief over the last 4 or 5 years, but particularly the last 3 years, in terms of the impact on all healthcare workers, no matter what tribe they belong to. And so we have in the UK, as many of you know, we have a reporting system on adverse events, and we've carried that out since 2008 or 6 to 8 when we started. And that's created a huge database of adverse events recognized by the staff of the NHS are failing in that, and that's millions within that database of incidents. Our failing, though, was that we didn't create the same portal for our patients or their families. And what we have found in recent times is that consistently, as an organization, healthcare, no matter which country it's in, has failed in its duty to support patients and their families when things have gone wrong. We take too long to investigate an incident. We do not allow patients and their families the same access to information that they require. We often see hospitals preventing the sharing of information, or systems preventing sharing of information. And so for one of the other elements for me in terms of addressing some of the basic issues is power. And where is the power in this dynamic? Is it with the patient, who is, if we believe our own rhetoric, that the patient is at the center of their journey? But often we find it's not the patient at the center of the journey, it's the clinician or the commissioner, the payer, or the hospital. So where are our patients in that? And within that power structure, how are we working within the hierarchy that exists currently to see where our patients should be? And I'm talking about hierarchy in a positive influence. I mean, it's important to have a hierarchy in some situations. And particularly when we deliver care through an expert model. But are we really thinking about it carefully enough in terms of supporting our patients and their families with the same level of literacy that we believe we have in this debate? And it was great to see the platform, the Austrian platform for literacy coming through, because we do have to give our patients and their families the same level of expertise in supporting their journey when things have gone wrong.
Thank you very much.
I'll withdraw on too much. Sorry.
Thank you very much. Maybe I would like to continue with Christine. Did you get any responses on how the patients using the checklist felt? Because it's like when they're at the center of it, if they get a checklist, this is the center of it, I guess. Yes.
Yes, we do. We have interviewed quite a lot of patients that have used the checklist. And we get feedback that they find it, they feel more in control of their own situation, they feel better prepared, and they can ask questions. And also they find it easier because we have links in the checklist, so they can go into safe information and read. Some hospitals have better information sites than others, but the ones that have good, the patient's experience is easy to find the right information. So yeah, and a lot of patients that are in the study, some of them have asked again, can we have it again if they've had a second surgery related to something else? They actually contacted us and asked to get it again.
Yeah. So I think this is the most positive feedback you can get, to want to do it again. Daniela, which kind of support structures would you say are needed? Because Annemarie mentioned them before, for all these platforms to work well and to strive?
I think so. Yeah, no, it works. I think it's important to have a platform just to connect people like this event today. It's important to just exchange experiences, create new thoughts, new projects to work together, but also supporting structures like further education, trainings, webinars on the issue, just to spread the word about it, to get more knowledge into the people implementing the things and doing the things. Quite important. And I think it's all about relation and trust. Does it work? Yeah.
Yes.
No, sorry. And it also does need trust and relationship. And I think that's also important, just to have trust, who can speak up and say, okay, maybe something happened and it's not right, or I'm feeling insecure, so that I'm not only allowed to, but also to feel innerly it is appreciated that I do this, because it's important, because we only can work together to,
So this would be almost the perfect link to the next session after the coffee break with safety and culture. So the culture has to change.
Definitely.
Thank you for this. And I know this hasn't been going for too long, but I'm very sorry I have to ask for your concluding statements now in order to have some coffee afterwards. But the good thing about the breaks is that you can use it to chat and to network. And there is the evening event that Michael Wagner announced beforehand. So what changes will be necessary, both for patients and healthcare workers? And very short answers. I know it's a very big question, for it to work well, to go from passive to active.
So I think what we've already heard, we need more platforms for exchange and more support structures. But I think it's also very important that we generate in future positive examples that demonstrate the added value of patient involvement to convince others to be brave and integrate patients, because I know it's not always easy to do that, and that it takes several feedback loops and makes projects longer, but it's worth of it, and we should generate that, such positive examples for it.
Definitely, thank you.
Absolutely with that, and agree with that. I'd add that, and it's interesting to hear Denny earlier on, that we consistently have not used the business case to support changes in patient safety. And so for me, I think it's actually starting to really understand the cost as well as the burden of harm. And that cost is what will open up the doors in terms of our politicians, our directors of finance, our boards. And so that's the burning platform. We can't afford to carry on doing what we're doing in the same model. And if we bring in citizen participation in that debate, who often contribute to some of their health costs through taxation or their commissioning costs through insurance companies, that's another way to unlock a bit of action, because I think that's exactly where we need it. So it's this partnership that should be really active between our politicians, our citizens, and the practitioners, and not just work in our own silos. Thank you.
Thank you.
Yeah, partnership was also the word I would use just to make it brief. I think partnership is key, that our collaboration among all partners to make it happen.
Thank you.
Yeah, I agree with that. And but I also think that it's important to find the right. Is it not working?
Push the button just once.
Just once. Okay.
Yeah.
I agree with that. That partnerships are important. But I also believe that we lack tools to involve patients, and we need to develop good tools for patients to know what they are going to do to be involved in their own care.
And be persistent on that, I guess. To have the tools, the platforms, partnerships. Yes.
Can I just throw in one more thing? Sorry, personal thing. So this is the year, as we heard earlier from WHO, of the elevating the voice of patients, and using the opportunity over as one of a whole generation of different initiatives over the next 10 years to do that. But I'm often reminded at home. I'm asked, am I listening? But am I actually hearing what the conversation is going on? And I think one of the other elements for me is to translate that your own personal experience into, are we really hearing the voices of our patients and our healthcare staff as they deal? And we're going to hear later on from Nancy and Emma about the impact of fatigue, but are we really hearing the issues of our workforce? Because unless we have a healthy workforce, our patients will continue to suffer.
So we take the active listening with us to the coffee break.
Absolutely.
And the program will continue at 11:20, and I'm really sorry for the delay.